Hi everyone, it's Pete here from the Pain Toolkit and welcome to another Pain Toolkit video. Now this afternoon, or should I say in Canada, it's good morning, but we're doing a three-way interview, and my massive pleasure as always to welcome Keith Meldrum, who's been co-authoring the Neuropathic Pain Toolkit with me. But we've got a guest speaker today about that, and it's no other than a doctor who's going to be talking about neuropathic pain. Now, rather than me sort of, as you know, I don't have neuropathic pain myself. Well, you know, I'm saying that not yet, and I don't really want it by the sounds of it. Is that I'm going to hand over to Keith. He can introduce Dr. Williamson, and then we'll go from there. Okay, so over to you, Keith.
Great, thanks, Pete. Well, I appreciate this, and good morning, Dr. Williamson or Owen. It's nice to have you with us this morning. Like Pete said, to get started, we're going to take an opportunity to talk a little bit about neuropathic pain from the perspective of a pain physician. So I'd like to introduce Dr. Williamson. So Dr. Owen Williamson is a specialist pain medicine physician who practices in metropolitan and regional multidisciplinary pain clinics in British Columbia here in Canada. He's the chair of the Academic Pain Directors of Canada and the Ethical and Legal Issues in Pain Special Interest Group for the International Association for the Study of Pain. Dr. Williamson believes the engagement of people with lived experience is vital in the development of community pain education and supported pain self-management programs. He is a passionate advocate for people living with pain and the development and implementation of provincial and national pain strategies. So with that perfect introduction, because it touches on a few things that we'd like to talk about this morning, I'd like to welcome Owen to our Pain Toolkit interview, and thank you for taking the opportunity to do this today, Owen. So thanks.
Well, thank you very much for the invitation, Pete, and thanks for the conversation, Keith. I always look forward to talking with you.
I appreciate it. So what we wanted to do was just sort of take an opportunity to just talk to you in your role as a pain physician, and in my opinion is one of the leading ones in Canada in the work that you're doing, about neuropathic pain, because I hesitate to use the term different, but you know, it's the pain that I live with, but it is a little bit different from people who live with it as far as sort of how it presents and what it can feel like, but the underlying theme and tenets of self-management sort of are across the board. But what I find in my advocacy work is a lot of people who live with neuropathic pain do feel like it's a little strange, and sometimes it's not understood in the healthcare system. So just wanted to talk to you about a few things in your experience as a pain physician about what neuropathic pain is, and self-management in that role. So with that, if we're all good, we'll just sort of jump right into this conversation.
Excellent. Well, perhaps I'll start off just by briefly mentioning what neuropathic pain is, so
yeah,
that the viewers can understand that. And so neuropathic pain is what people commonly call nerve pain. And it's a different sort of pain, which is why it confuses people. Traditionally, we think the pain is due to an injury. So for instance, if I cut my finger, it causes pain. But the process is such that there are little receptors in my finger that detect the tissue has been damaged. Then those little detectors send signals via nerves to the brain, where the brain interprets those signals as a danger signal. And as a result of that, I look down on my finger, I see it's cut, and I do something about it. Neuropathic pain or nerve pain is different, because in most circumstances it's not a problem with a cut in the finger or even a problem with the little receptor that detects the tissue damage, but it's a problem within the nerve itself. And so that what happens then is that the nerve itself sends, if you like, false signals to the brain, which get interpreted as pain. The tricky thing about that is that our brains are programmed to look for danger at the end of the nerve. So if I feel pain coming from my finger, I look at my finger and see the cut. But if I have a problem with the nerve coming from the finger, I will still feel that pain at the tip of my finger, but when I look at it, it looks normal, and that's very confusing. The other thing that's confusing about nerve pain is that if you cut a nerve, you get numbness or weakness. But if a nerve is damaged, you can get increased sensation. So in that circumstance, people will talk about a sharp or a stabbing pain or an electric pain or a burning pain. Some people, in fact, talk about itch rather than pain. So there are all sorts of different phenomena. But if you, a typical example of an abnormal feeling that you can get from a nerve that's not actually nerve pain is when you rest on your elbow and you get pins and needles in your hand. You're not actually, you look at your hand, I don't actually have pins and needles in it. I can actually, with my hand, it seems normal, but yet I feel the sensation. So in a way, nerve pain confuses you because you think it's showing damage at the end of the nerve, whereas in fact it's caused by a problem along the pathway of the nerve between the finger, if you like, and that part of the brain that warns you that you've got something dangerous going on.
So it is, yeah, I mean, that's a great explanation. And I just think of my own experiences and how I was never actually formally sort of diagnosed with neuropathic pain. It actually came across in kind of an ad hoc, almost tangential way. So I had all these years of feeling and experiencing all those things and wondering what was going on. So when it was contextualized into neuropathic pain, it allowed me to start to research more and understand it a bit more, because it can be very confusing and upsetting and strange as the person living with it. So the other question that I have for you is, in your experience as a pain physician, how do you see neuropathic pain as it's understood within the medical community? I mean, you're a specialized pain physician, so this is your area of specialty, but sort of with other healthcare providers, is there really an understanding of what this is, or do they know when people present with some of these odd sensations, what they're really looking at?
So I think that most the physicians, including family physicians, will recognize specific forms of neuropathic pain. They will recognize that, for instance, people with diabetes who've got burning feet have got what's called a neuropathy. They'll recognize that people who have got a disc prolapse will get neuropathic pain down their leg, which they call sciatica. But they don't recognize very well conditions where pain or abnormal sensations are amplified. And so it's confusing for patients, it's confusing for physicians. And the other thing that is concerning both for physicians and people living with nerve pain is the different quality. It's unpredictable. It comes on spontaneously. And it's not like other forms of pain, you know, that if I've got a cut finger and I push on the end of it, it hurts. And if I take it away and don't push on it, it doesn't hurt. That's not the way neuropathic pain works. It seems totally random. And because it's random, people find it harder to understand and harder to control. And therefore, they find it more frightening.
I think that's a really excellent point. And again, I can only relate to my own personal experiences, but from others that I've talked to that have been diagnosed with neuropathic pain, it's that randomness, which adds to that sort of sense of just confusion and fear to some sense, because like you say, it'll just sort of come on. You're not doing anything and you'll have these very odd pain flares and you're like, what's going on? As well as the really odd sensations. And I recall talking to one of the nurse specialists once in the pain clinic that I see, and I asked her, like, I don't understand why my shirt, so my pain is left abdominal wall. And I said to her, I don't understand why my shirt will hurt against my skin. And she's like, oh, well, that's very, typical of neuropathic pain. And I'm like, of what? It was just sort of like kind of the first time it had been introduced to me. So it's not that a definition makes it all better for people, but it certainly helps better understand it. And when you put a name to it, people can start to feel like it isn't all in their head if they're crazy, or that this electrical burning pain when they're just sitting there doing nothing isn't because they're insane. It truly is the way their body is functioning. So yeah.
Another example of a confusing neuropathic pain is that if people who have diabetes and nerve pain, they'll find, affecting their feet, they'll find that they can't put the covers on their bed on their feet because the brushing of the covers hurts so much. But on the other hand, they'll come into my office wearing thick socks and heavy boots. And you think, how does that fit with not being able to have sheets brush across my feet? And what they're actually doing is packing the stuff around their foot so it doesn't move, because it's actually it's not the direct pressure that causes the pain, but it's the rubbing across the surface. So again, that can somewhat seem counterintuitive unless you actually have the knowledge about what neuropathic pain is and how it can present.
I think that is really important because I'm quite confident saying I know that helps people feel, for lack of a better term, better about what they're experiencing, because it is really, really confusing and frightening and odd. You know, I tell stories about, for me, it's the shirt against my skin. When I have a shower in the morning, I typically have my left arm against my side because the running of the water going down my side will hurt. And you're like, how can a nice warm shower, which is supposed to be soothing and relaxing, cause me so much sort of distress and pain sometimes? And you do get thinking, what is wrong with me? Like, I am nuts. So to understand that, nope, that's the way it works. And as you've explained, some of the underlying, physiology behind that helps people, I think, better understand what they're dealing with and be able to live with it.
That's a really interesting example you give, because a temporary but common form of this, of course, is that the pain that you get with sunburn. People are aware that if they get sunburn and they stand under a cool shower, it feels burning hot. But
Right.
if you can't see the sunburn and you get the same sensation, then that can be quite frightening.
Absolutely. And it's that frightening that, and now whether it's neuropathic pain, and I know that's our focus for this, but I mean, it's that fear or that concern, which when people are, who live with pain, are better to understand and put some rationalization to it. That's what helps them be able to start to look forward and to do the things they need to do to help themselves better live. But when you're caught in that fear, you get really, really tough to find a path forward. So.
Yeah. And unfortunately, that has a lot of other negative consequences. So for instance, we know that compared with normal forms of pain like cut fingers, bruised knees, whatever, with neuropathic pain, people feel a lot less in control of the pain itself. And as a result, they feel a lot less in control of their own lives. And unfortunately, then that gets reflected ultimately in greater risks of depression and suicide. So it's really important that we educate people as to the nature of chronic pain to be able to alleviate the fear, to promote understanding, and also hopefully to reduce those potentially life-threatening consequences of the pain.
Absolutely. That knowledge, well, not the panacea, certainly goes a long way in allowing people to start to do what they can to help themselves, which I think leads us into a great sort of conversation about self-management itself. So, we now have a bit of an understanding, from the medical standpoint, what this interesting phenomena called neuropathic pain is and what it feels like. And, now that people can understand that it's real and all of these strange sensations that they have are real and valid, what can they do to help themselves? And now we start to talk about this important tenet called self-management. So in your experience, as a pain physician, what do you see a person's role is in self-management when they're dealing with neuropathic pain? I mean, pain in general, but neuropathic pain.
So I think the main thing about, I still struggle with the term self-management in itself. And the reason I do that is that when you talk about self-management, and particularly to people in distress, they can misinterpret that concept of there's nothing more I can do as a physician, it's all up to you, off you go. And as a result of that, patients or people who are in that situation can feel abandoned, and they can feel hopeless or helpless. And in fact, that can actually add to this problem of depression and whatever. I think we need to change the name, and I'm not sure that people do this because he's already published the books, but I think we need to talk about more in the way of supported self-management or guided self-management. And it's all about a conversation between the people who have pain and those that care for them to ensure that it's a team effort. It's not just up to the physician or the healthcare professional. It's not just up to the patient, but there has to be There has to be a collaboration between both sides, because there are things that physicians can offer patients that patients can't do for themselves, but then there are things that patients have to do for themselves that can't be provided by healthcare professions. And another way of looking at it is, and I haven't got the math in my head, but you might see, if you come and see me as a pain patient, you might see me for 15 minutes 4 times a year,
Right.
60 minutes. And then you work out the number of minutes in a year where you're not seeing me, and you have to have resources to be able to control or manage your pain during that time. Or even if you can't control or manage the pain, control and manage your life. So one of the things I tell about my patients is that if you have neuropathic pain, life will be different, but it doesn't have to be worse. And it gets back to this old thing about saying, and it's not meant in a flippant way, is that pain is inevitable, but suffering is optional. And really the self-management side of it really helps people control their distress and maximize their function despite their pain. So that's part of the message that we had to get out as part of the self-management thing. And then everyone will have a different way that they can best control their pain and distress. And the important thing about that is that there is no one solution that fits everybody. But what we have to do is try and provide people with a whole range of solutions so they can try them and find out what works for them best under certain circumstances. So in some circumstances, it may be just resting for a short period of time before moving on. It may be pacing your activities during the day so that you accept and recognize that things will take longer, but you can still accomplish them if you break them up a little bit. It may be teaching relaxation techniques so that when you get the pain, you often get very anxious, and that if you control the anxiety component of it, then the pain doesn't feel so bad. It might be teaching people more about sleep hygiene so that they get into a regular routine so their sleep quality improves, because we know that if someone has poor sleep patterns, that will make their pain worse. It's also about recognizing that you're getting into a bad place as far as your mood is concerned, and maybe trying simple things to help that yourself, but also knowing the point where you need to go and seek help from outside. And so self-management is not something that we can do intuitively. We have to be taught the techniques, and then it's up to the person with pain to actually practice the techniques in order to, as I said, at the end of the day, maximize their function and their quality of life despite the pain. In a way, pain, one of the confusing things about pain, and people misinterpret when I say, at the end of the day, pain is just the way your brain interprets a particular set of signals arriving at it from the body. And people will say to me, you mean it's all in my head? And unfortunately, that's a pejorative term, and they seem to think that if I suggest that, I'm suggesting they've got some sort of mental health disorder. Well, it couldn't be further from the truth, but the fact is that to the best of our knowledge, we interpret signals as painful in our head, in our brains, and our brains are in our head. Therefore, there's that confusion. But I always reassure my patients, your pain is real. This is the way that you are interpreting signals coming either from the cut in your finger or the abnormal functioning nerve, or in fact, just because of the way that your brain is set up. The software in your brain means that when you get certain signals coming to it, you interpret it as pain. I think that's really important that you realize that that's all it is. It's not all it is, but it is all it is, because that actually frees you up. Once you realize the pain signal is not a signal that something is nasty and dangerous, then it is safe to persist and to improve the quality of your life despite the pain. And so, yeah, we need physicians who are trained well enough to be able to reassure patients that although they've got pain, it's not dangerous pain. And then we have to have the patients who under those circumstances then are willing to try these other techniques in order to improve the quality of their lives.
What I love about that is just that I think you've hit on like three what I think are really important points that Pete and I have talked about probably ad nauseum. So one is the validation of a person's pain from the healthcare provider, and like you said, it's the way you've described it is I think very very appropriate, but it's validating. Your pain is real, and underlying all that is it might not necessarily, unless there is an underlying biomedical issue or biomechanical issue, but let's say that's been ruled out. Your pain is real. And that willingness, I love that term willingness. There's acceptance or willingness. I like willingness to say, okay, I understand it's real. I'm not damaging anything inside of me. So there are things that I can do to help myself. So there's the validation, the willingness. And then I love, a slide that Pete uses where it talks about that relationship between the person living with pain and their healthcare provider is the healthcare provider is that coach. And I think that relationship is really, really strong. And Pete, I'll use our Canadian analogy of hockey because that's what I know so well. The coach's job is to take their players, teach them, foster them, mentor them, support them, and say, here are the skills you need to be the best. And I was a goalie in Pee Wee. I was the best Pee Wee goalie goal. I was going into the NHL, man. I was sure of it. But here's the best goalie that you can be. And I'm going to give you all these skills, but you have to go out and practice them. And some days they're going to go well, and some days they're not, and you've got to adjust them. But give them the skills and the tools to help themselves. But be there for them when they need that support and to go back to them. So, it's the validation, the willingness, and that support. And that's why I like your term. You talk about supported self-management, Owen, and I think that's really important and something that is probably, I believe, still lacking very much in the healthcare system. So. Mm-hmm.
I just I'd make a comment there because when I first started my sort of journey in living with pain, it was back in the early 90s, and I believe we've been racking my brain the last few weeks really because this self-management term keeps coming up all the time, and I don't ever remember actually anyone saying to me, "You need to learn to self-manage."
Yeah,
I think from memory it was about managing pain or pain management. So for me, I think self-management is, I think, a fairly new term. And even when I'm doing workshops for healthcare professionals, I ask them, what does self-management mean? And a lot of them actually struggle really, because I think, well, it's like, well, it says it is what it is, self-management. Yeah, but what is it? Can you give me an example of it? And they really struggle. So, I think I'm with you, Dr. Owen. I think, can we use other terms? As Keith says, I think. Do you know what I asked healthcare professionals this as well? I said, I think you guys need to be seen more as coaches, rather than take off your sort of medical hat and put on your sort of educational hat. And
so I would. The only thing I'd do to disagree with that, Pete, and respectfully so, is that I don't actually think that physicians are adequately trained or are the best people available to educate people living with pain or coach them. And I think that there are people who can do that, who can do it a whole lot better than than physicians. And I think a part of this, the solution to this problem is actually changing the perceptions amongst people living with pain or any other disease as to where they best get the skills or the coaching they need. And I think that traditionally it may have been the physician who was responsible for all of that. But I tell you, if I want to design an education program, I talk to educational experts, not physicians. Okay, now I learned some things along the way, but again, as an aside, perhaps one of the best adult education programs I'm involved with is the Canadian Ski Instructors Alliance. But in developing their teaching program to teach people how to be ski instructors and also for ski instructors to teach clients, they employed professional educational people to develop that message. And at the end of the day, and I want to put it right here because I don't want to forget it, is that the most important people to educate the educational people are the people with lived experience. And so again, this has to be a situation where the people with lived experience also realize that they're experts in pain, and that they're the ones who should be helping the physicians both in their own education and to be able to help others. So that's why it's a collaboration, but it has to be a collaboration with people with lived experience, and it has to be at the other end of the spectrum, it has to be patient-centered in its output and its outcomes.
Totally agree. Love it. Well, I was thinking from the same hymn sheet, as they say.
Yeah, yeah, absolutely. And I think we're starting to see a little bit of that change starting to happen. It's very, very slow, where academics and researchers are starting to look to integrate people with lived experience, to get them into the ground level, to say, help us develop this program. But it's really, really new. And I think some of it is still being done because they think this is what they need to do, because this is what they're looking to do. But until we make that change, Owen, I think you're absolutely right. It's not going to be as effective as it could be. That term collaborative is used a lot, but it is no more appropriate than in this context that you just used. So you just summed that up very perfectly. So thank you.
It's interesting. I was informed, I was on a institutional ethics review board back in the 90s. And that was when we, in Australia, we were still going through the HIV/AIDS. Wasn't a crisis, but it was a major health concern publicly at that time. And we had people with HIV/AIDS on our ethics board. And I learned more from them than I did from any of the other physicians or scientists or experts. And they just gave the most practical common sense because they knew what they needed. And I think that that's a message then I've tried to practice over the last 30 years, and hence I advocate. But the big problem is, with people with chronic pain, and particularly perhaps neuropathic pain, because it's one of the long-standing chronic forms, is that they tend to lose their voice. And we have to actually help patients or people living with chronic pain to regain their voice so they can tell us what they need. I find it somewhat ironic when I talk to you or to Pete about this, because you're actually professional people with you're people with professional lived experience, and already the message that you give up has been filtered through your knowledge and experience. But what we really need to do at the same time is find a way to listen to people who haven't spent as much time thinking about pain and its consequences than you two have. If you like, the grassroots, and ultimately this does have to go back to the grassroots. We're all in our ivory towers at the moment. We're full of good intentions, and we're developing these tools for people living with pain, but we still need to get in the trenches and talk to them directly to find out what they want and whether what we think they need is actually appropriate or not.
I think me and Keith would love to do that. But
yep.
As usual, it's lack of resources and stuff like that, because they see it as a bit of a... I've always seen sometimes like pain self-management always being sort of the bridesmaid and never the bride's, And we've always been like self-management. It all seems to be not resourced as it should be, really, and it seems to be for a lot of healthcare professionals. Not you, because you seem to be one of the better guys around, but it's easier, I guess, and simpler just to sort of give another tablet or a treatment or something like that. But self-management is for someone living with neuropathic pain or long-term pain, it's getting them back in the driving seat, because I think a lot of them feel that they're in the passenger seat and they don't really have to do anything, And self-management really is about taking action. It's about getting back in the driving seat and getting on with your life the best of your ability, in spite of, as you said earlier on, living with the pain itself,
Yeah, and I think that's why, at the end of the day, education is so important in this. When I talk to health ministers about this, the first thing they'll say is, well, what do you want? And they expect me to say, like, more money for what I do. But the first thing I always say is education. And I honestly believe that education regarding pain should begin in primary schools. I mean, because then we destigmatize pain, we explain it, people aren't so fearful. The best time to talk about pain is before you've got it.
Yes.
But then because once you do that, then you know that when you do inevitably get it, there are already resources out there that you can use, and it changes community expectations. It's not that, okay, I need to run and see my family physician, I need to run and see a specialist. I might try these local resources first, because I know that 95% of my pain is going to get better, and that if I get into this network, then that will be fine. And that's actually a more rational way of using the limited resources we have, because they will always be limited. So that's why I think that we need to, as part of any supported self-management program, we also have to teach self-advocacy. I mean, around the world, we know that about 1 in 5 people live with persistent pain. I was talking to one of the professional pain advocates in Canada recently, and I told her, you realize that means that 1 in 5 voters live with persistent pain. And she'd never made that connection before.
Right.
But as a voice, people living with pain have got a great voice should they gain the confidence to use it. And I think that as part of any supported self-management program, we also have to teach self-advocacy. Absolutely.
And I love how you've tied, I talk about grassroots and talk about a need for a grassroots movement. This is absolutely it. And your point about starting to educate, at the primary level before it becomes an issue, so that when it happens, it is not fearful, or it's just, oh, this is what we do. And getting, Pete's talked about this before. It's his analogy of teaching the young kids about recycling. It just becomes part of their world. We make it part of their world, so that the way I grew up, when this happened to me, it wasn't this odd thing that was scary and fearful. I didn't know what to do, and I ran around in circles trying to figure it out. I had the tools and the knowledge to try some things, just as you said, Owen. So that education, that knowledge, that's key to getting through this. So yeah. Mm.
I think one of the things is, and this is what I like about the technology we're using now, we can actually distribute the message into regional and rural and remote areas using these sort of technologies. And we already have the studies to show that if the content is delivered in this way, then that can be beneficial. More so that it means that, because we know that there are periods in the lives of people who live with persistent pain, they're unable to attend classes or appointments at a fixed time on a fixed day. At least from these providing information and providing guided relaxation classes or whatever, these can all be provided online and archived, so that people can look through these resources at a time that suits them, not only given the other demands they have on their life, but also taking into account the restrictions their condition places on them.
Absolutely. So
do you want to wrap things up? I'm just going to ask you guys for like a take-home message. What would be your take-home message? So someone's been watching a video, perhaps for the first time. They're in a little bit struggling a little bit. So what would be your take-home message to the person watching this video now, who's downloaded the Neuropathic Pain Toolkit, perhaps been browsing through it, etc., and then they come across this interview or conversation? So what would be your take-home message to that person, to actually give them a better motivation, really, to get more involved in pain management, self-management?
Well, I guess my message is that people living with persistent pain, particularly neuropathic pain, my message is it's real, but it's not necessarily dangerous. The most important thing is that you assemble a team around you but you're an active member of that team. And that, like everything else, whether it's riding a bike or playing the piano, you've got to practice. The more you practice, the more benefit you will receive. And really, at the end of the day, if you want to get the most out of your life, you seek out more tools for your toolbox, and you keep on pulling them out whenever you need them.
Yeah,
I love that one. Keith, what's your take-home message, man?
I think, I just have to echo that. It's, your pain is real, not necessarily harming yourself, and to come to that place of willingness to do those things to help yourself. And it's not easy, and it's practice, but it's not it's a marathon, not a sprint. We're not going to race to the finish line. We're going to work our way through this. And you're going to have days where they're better than others, and you're going to have a little bit of setbacks, but just stick to your plan and keep working on it. But have that team around you of support, if you can. Some people aren't fortunate to have that, but if you can, have those supports around you, and focus on doing everything you can to live as well as you can despite your pain. So, yeah.
Well, thank you very much. My take-home message to anybody watching this is, listen, I'm not an academic. I'm just a normal guy in the street. And I'll tell you what, if I can do it, you can do it. So just take it one step at a time. As Owen and Keith has said, get a team around you. Most importantly, I've very rarely met anybody who's done this on their own.
Yeah.
So you need like a hockey coach or a football coach, soccer coach. It's a team effort. So it's about who you choose in your team. Don't forget, you can transfer people out anywhere, anytime you want. So listen, take care. Thanks very much for watching. Keith, thanks very much for organising the conversation. Dr. Owen, I could say Dr. Williamson, but I always call doctors by their first name. So Dr. Owen, it's been a pleasure meeting you. I've known you got to know you on Twitter and stuff like that. And it's been really a pleasure and an honour to actually speak to you online. It's been a fantastic conversation. And I think that the good thing about digital information, which is like the downloadables, like the toolkits and other stuff, is that we can, do more in conversations, and I can, just update the information, etc. as time goes on. So anyway, it's a night time here in the UK, and I wish you a fantastic day, you two guys. Be cool and groovy. And wherever you're watching in the world, whether you're watching it in the morning, afternoon, or evening, take care, and we'll see you again on another Pain Toolkit conversation. Take care.
Thanks, everyone. Thanks, Owen.
Thanks. Thanks for having me, Pete. Thanks for the conversation, Keith.